Good afternoon, everyone, and thanks for spending a little bit of time with us. We're roughly 5 months into this COVID-19 pandemic. What a difference the month of March makes versus where we were all headed up through February. Well, at this point in time, we've had more than 135 admissions or so to Tahoe Forest Health System that were ruled out or directly related to COVID-19. We've tested 167 positive lab tests within our health system out of about 3,100 total tests. And certainly within our region, we track especially Eastern Nevada, Washoe, the Incline, Village area, Crystal Bay, and Eastern Placer. And in those three areas, we have about 296 positive lab tests. We certainly have seen it grow quite a bit since the month of May. We're seeing a few days overall of slight slowdown, so we hope that trends into a longer period of time. But I think that we're still learning a lot about this disease. There certainly isn't any type of herd immunity out there, and we don't have vaccines. So certainly we want to protect our elderly out there. I'm just really proud of the innovations that our teams have put together, both in Incline Village, their drive-by clinic, and all the other work that they're doing in the upstairs clinic and the ER. They're doing an amazing job there, and our team here at Tahoe Forest. We've had some fairly complex patients that have been in for a while and critically ill, and all of those have been able to return to their families. So we're really grateful for that. There is quite a bit of activity going on in the country right now about antiviral testing, about vaccine development, and the third phase testing of some of that. So we're certainly all listening and watching for that. One of the things that we're really pleased for as a health system is that we have a much greater increased ability for any symptomatic patient to do rapid testing of those patients. For asymptomatic patients, it can be a frustratingly longer period of time, but for patients with symptoms, we're really thrilled to have quite a bit of reagent capacity for rapid testing. We hope to strategically, we're looking to have at least 2 brands of lab equipment and reagents on hand. Hopefully the second brand will be available in September and available also in the indefinite future to help us in Incline Village and in Truckee as well. We do want to thank all of our communities that are really following the advice pretty well, in terms of masking, in terms of physically distancing. And I think about 82% of the deaths generally have been hitting individuals over 65. So we certainly want to protect, our older residents until we can just get to a better place with this. But we're really happy to say that our inpatient hospital activity ranged from 0 to 7 in the month of April. It dropped to 0 to 4 inpatients in May. It was 0 to 8 in June, with June 30 being the only 8. And then in July, it's been 0 to 7 with 0 or 1 in recent times. So we're happy that our patients haven't required any significant change in hospitalizations over the last 5 months. So that's our brief update. We have really reopened our volumes. Really all diseases and injuries are important for timely treatment. We can't stress that enough. Heart disease and cancer and other diseases weren't somehow magically cured, during this 5-month period, and thus, the caseload of those have dropped quite a bit across the country. So we're really concerned that patients get timely review and treatment of all health issues. And so that's kind of it's our local message, but it's also a national message out there across America as well. So we thank you for spending time with us, and I'll end my message.
Great, thank you so much, Harry. And I'll have the chat box open, so any rolling questions, I can certainly go back and direct them to Harry. But now I want to hand it over to Judy Newland, who is the COO of the Tahoe Forest Health System and our incline administrator, who will provide a brief update as well.
Thank you, Carly. And I think for right now, I'm actually going to defer to Dr. Coll. I know that Dr. Coll is going to be giving an update on where we were, where we are, where we're going. And so I don't duplicate what she may be sharing. If I have something to add at the end, I will, but otherwise thank you for allowing me to speak briefly, but I'm going to go ahead and let her begin.
Sounds great. So I'm really happy that Dr. Shawni Coll is with us today. As she mentioned, she's our Chief Medical Officer for Tahoe Forest Health System and certainly has been instrumental within the process of reopening and the phasing and how Tahoe Forest responded to COVID-19. So I will pin you as the main screen, Shawni, and you can unmute yourself.
Awesome. Well, I just want to, first of all, thank you all for being engaged with our foundation and being interested in what I have to say today. And I hope that some of the tidbits that I bring you today really tells you what kind of health system we have here, what kind of medical staff we have, and the support of the executive team to really make sure that we are doing the best that we can for our community. So I'm just going to go through quite a few points that I just thought were really instrumental in what we did, and then also kind of where we are with testing, and then move on to kind of some hurdles that we're looking at in the future and maybe how the foundation could potentially help with that. So I think the first and foremost thing that we as an executive team did in conjunction with the medical staff was we decided to follow CDC, which is, as I'm sure you all know, the Center for Disease Control's recommendations. Now, we also have some recommendations that come through what's called CDPH, which is the California Department of Public Health, and we're also under those regulations. But, you know, that was a guiding principle and has been continued. We don't do things willy-nilly. We make sure that there's true evidence base behind everything that we choose to do as a health system. And then I think one of the earliest things that Harry and the executive team did was they pulled me from clinical duty. So I am typically about 40% time OBGYN and 60% time chief medical officer. But back in March, they pulled me from the majority of my office duties. I did still take call so that I wouldn't burden my partners with extra call. And I was focused mainly on working with the executive team, including my chief nursing officer, Judy Newland as the chief operating officer, obviously Harry as the CEO, to really make sure that we were attacking this situation in the best way possible. So I thought that that was a great commitment that the health system really felt like we needed physician leadership during this time. Then what I did was I asked my medical staff colleagues to make sure that they were combing all of their colleges. So for instance, as an OBGYN, I am under the auspice of the American College of OBGYNs, and they have certain recommendations that are super important for all of my clinical care. So I had every single different specialist combing their colleges to make sure that the American Academy of Cardiology, the American Anesthesia Association, the American College of Surgeons, that we were all following the most up-to-date current guidelines for those different types of specialties, so that we were definitely making sure that we were following the recommendations during this COVID pandemic that were needed with each different specialty. Then as a medical staff, we developed disaster privileges. What that means is, for instance, I am currently privileged at the hospital to care for women both in the birthing process, in the emergency room situation, surgeries for hysterectomies, etc. I have medicine skills that could be applied other places if that's what needs to happen at that time. We have emergency room physicians that would be. We have inpatient physicians, hospitalists that could work in the emergency department if needed. So what we did was we first elicited information from the physicians on what skills do you have that we may not know about. Where do you feel comfortable doing? We have a lot of family medicine doctors that could deliver babies if all of a sudden your 4 OBGYNs all got COVID and couldn't care for our pregnant women in the community. So we really elucidated all about that important information, where people were willing to work. For instance, we have a lot of family medicine and internal medicine doctors who only work out in the clinic, but were willing to come in the hospital and take care of hospitalized patients that were ill if we had a staffing shortage. With that, we then have to make sure that they have the skills and the privileges and the abilities to do those things. So we don't just say, oh, sure, you want to deliver a baby, that's fine. We actually have to validate all of that information. Oh, you actually delivered babies for 3 years, 5 years ago, and you've done it recently enough. So we put them through the rigors of that. They have to apply for disaster privileges. The other thing the state of California and the state of Nevada did was if you had a medical license for one of those states, you could apply for privileges, or excuse me, licensure in the opposite state. So for instance, I currently hold a California medical license and I am not licensed to practice medicine in the state of Nevada. However, with our health system, knowing that we may have a crossover between our two health systems, I needed to make sure that I could also practice medicine in Nevada. The state of Nevada gave me a waiver. I had to apply for it, and the medical staff office was collecting all of this data. I then was able to apply for disaster privileges in Nevada. Something, though, that is interesting that you guys should all know is that I applied for these privileges, but I have never actually received disaster privileges. And the reason was because we never needed it. So we basically did all this preparatory work so that if I said to Harry, who is the one that can sign my disaster privileges, if I said, you know what, I'm going to deliver a baby at Tahoe Forest, and then I need to transport all of these postpartum patients over to Incline to be taken care of over there because we have too many patients at Tahoe Forest, and we need to get these babies and moms safely out of the hospital that is infected, you know, that has too many infected patients, and get them to a safe haven. He could then sign those privileges immediately. That day I could go over and round on my patients over in Incline. So this was all set up just in preparation for what we thought was going to be a large surge. And we just want you to really understand how much effort that took to prep the medical staff to make sure that we had physicians that were either licensed in Nevada with a waiver to practice in California, or vice versa, a license in California with a waiver in Nevada. And then also just the planning that went into it. So for instance, Dr. Clyde is one of the family medicine physicians over in Incline, and he was prepared and willing to take care of all of our pediatric patients over there, along with Dr. Vayner, who's a pediatrician. But we can't just rely on only one physician. So we need to have backup, which is kind of what we did through this whole process. Now, on top of all that privileging, because of our EPIC electronic health record, we also have to train people on how to potentially work in a different setting. So all of our emergency room physicians got trained in the inpatient electronic health record, so that basically with a moment's notice, we could deploy all of our specialists in potentially different areas that they're needed. We also want to just remind you that we have a very amazing group of advanced practice providers, which are our nurse practitioners and our physician assistants, and they also went through the same process. So when they had extra skills, like a lot of our family medicine and our surgical PAs have worked in the emergency departments before. So they were able to apply for disaster privileges to work in the emergency department, and then got trained up on the emergency room module within our electronic health records so that we could deploy them as needed. I also want to just say that I've been super, super proud of my medical staff. I have heard across the country how outpatient family medicine docs would not be even willing to come in the hospital, or emergency room physicians wouldn't be willing to work as hospitalists. I'm telling you, 98% of my medical staff said, you tell me where you need me, Shawni, and I will be there. Our medical staff is amazing. They are willing to do whatever needs to happen. Our general surgeon said, we'll take care of every belly pain in the emergency department. Let the emergency room doctors take care of what I can't take care of. So that was really a very positive thing and something that I'm very proud of. We also really looked to what people's interests were and how we could really extrapolate and feed off of that energy. Anytime we had a new process in place, we used what's called high reliability organization principles. And that's really looking at a system-based fix so that any person that you put into this new situation will be at the same advantage as anybody else who's worked there before. So as we did all of these new processes, we really made sure that we were looking at it from a high reliability standpoint. So a couple of the different projects that we did was we developed a clear guideline for our PPE. Now, PPE is our personal protective equipment. It's what makes sure that we don't get COVID when we're caring for patients. We had a tiered system with a level 1, a level 2, and a level 3. And in those, it tells you what kind of patient you would need to be seeing for level 1 to be appropriate, what type of patient would be level 2, and what type of patient would be level 3. Not only did we develop these guidelines and clear so that staff, physicians, anybody who is going to be around those patients really knew what they should be wearing, but we also had simulations on how to don and doff your PPE. That's putting on and removing. What we know is that the highest risk for contracting COVID is actually taking off your personal protective equipment. So I would come out of a delivery and I looked like I could go to the moon. I was fully, garbed up, and a nurse would stand there and watch me take everything off to make sure I was doing it in the correct order. She would have a checklist of how I was supposed to take it off. And if I started to do something incorrectly, she would stop me and go, no, 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 remember you do this before you do this. And it was really a team approach to make sure that all of us were safe in what was happening. We also had a very large team that talked about how we can preserve our PPE. As I'm sure you guys all heard, there wasn't enough PPE in New York. They were getting ill because of it. Medical students didn't have it. Some interns passed away. Young, healthy physicians that were in their first year of training passed away because they did not have appropriate personal protective equipment. So one of the things that we did was to develop a cleaning and sterilization process where, again, using high reliability principles, we got a team together of our sterile processing department. We had registered nurses, we had physicians, we had materials management, which is who can order all of this equipment for us and was ordering as much as they could get their hands on. We had infection control. And what we did was we got together and really decided how could we make this the safest process possible with being able to reuse and safely reuse our equipment. One of the biggest things was what I'm sure you guys know is called the N95 mask, and it's a respirator type mask. And we used evidence-based medicine and protocol on UV light so that we could wipe down the mask and then have a UV light sterilization process. But in order to do so, what the physicians and staff would do is we would take our mask off while with our doffing partner so that we would not be contaminated. We would then take a brown bag. I put my name on the brown bag and what unit I'm in, and I put my soiled mask inside of it, staple it closed, and it gets sent off to our sterile processing. They then process it with a UV light in a standardized fashion. They hashtag that mask because we only want the UV light. It can degrade the mask, so we don't want to sterilize it more than 5 times. So they're actually marking how many times that mask in particular was cleaned. They send it back to me in a white bag, signifying this is your clean mask. Do not take a brown bag because that is your dirty mask. We did an amazing job of really being stewards of this critical resource and making sure that our staff and our medical staff were protected throughout the entire pandemic. I want to just give a shout out to our anesthesia providers. They have done an amazing job with their COVID response. They, as you probably know and understand, when it first occurred, we closed a lot of our operating room services down. They really did an amazing job with redeveloping their schedule. They had somebody on call 24/7 just for intubations. And the reason is that intubations are one of the highest risk procedures for developing COVID as a provider. So you want somebody that is the fastest, quickest, best intubator possible so that the risk is minimized without somebody struggling to intubate. So they developed a full intubation team. They also took PVC pipe and clear rain jackets to develop this intubation box so that they could see and have the droplets all contained within this box, and their hands would be inside the box so that they could intubate with protection for themselves and the rest of the room. And they also shout out to the emergency room director and nursing staff and physicians that they developed a whole intubation room down in the emergency room with specialized equipment in order to be able to service these patients there. I also want to give a shout out to materials management, who was able to get us all of our PPE with obviously the support of the executive team. They did an amazing job making sure that that was not, and once we had all of the cleaning process in place, you know, we were never short. Everybody had the appropriate equipment to keep themselves safe, which I thought was amazing. As you may or may not know, we actually started with a tiered approach of what services we would have. Those tiered approach is how we actually closed down the hospital, depending on what was happening at that time. With that, we then opened in a little bit different manner with kind of looking at what systems do we have in place to make sure that that particular area is safe. So it was opened in a little bit different manner than it was closed down, but it was very clear that we were able to kind of send out to the into all of the directors, the medical staff, everybody on how we would close the hospital down and how we would then be able to reopen. We also had a team that was called a clinical management team. This is a team of nurses, physicians, pharmacists, lab, quality, executive leaders, infection control. We got together on a weekly basis. We developed a website internally on what medications we had available, what clinical protocols we could be doing, and how we could take care of our patients the absolute best. We spoke about sequestering certain medications that were in shortage. We talk about using alternative medications when other medications are not available. We also developed research protocols for convalescent plasma. That is one of the things that can be super useful when somebody has COVID. Convalescent plasma is basically taking blood from somebody who's been COVID positive and has antibodies to it and giving that to somebody who's trying to fight the disease at the time. And so we were able to do a research protocol for that so that we could offer that to our patients. And again, we were, reviewing the CDC and the CDPH's websites to make sure that we were really on board with all of that. I have to give a shout out to Dr. Tom Simrad and the Ethics Committee. They did an amazing job mobilizing an ethics committee, and you think, well, why would you need an ethics committee at this point? It was probably one of the biggest struggles for the medical staff is who is going to get the resources if and when they're ever in such a sparse, scarce resource. So what they did was they developed a whole protocol on who would get medications and who would not, who would get ventilators and who would not. And this was so that if we ever got to the point where those decisions were extremely difficult, we could look to this protocol that was already developed for us, and it would try to take more of the emotion out of it and really have it be objective. This was super key and was a huge project, and they did an amazing job. And I want to say that I'm super thankful that we never got to the point where we needed it, but it is there in the future in case we have to use it. We also had weekly Zoom meetings with COVID updates. Every week with the medical staff, they took an hour out of their Sunday evening every Sunday. And that was so that everybody could kind of start off the week with the same information. We had about 85 participants every single week. And that's about the amount of our medical staff that is actively working here. So it was a very, very high attendance. Our physicians were extremely engaged. We answered questions, we gave data, we talked about statistics, and we talked about where we were going. So really quick on kind of our current state of testing. We have the Abbott ID now, which is about a 2-hour turnaround. Are you good, Carly?
Yeah, I just have a question before we have a lot of questions around testing, but one that was just related to what you were speaking about is how many ventilators does Tahoe Forest Hospital currently have, and what's the current availability of remdesivir? Okay,
so let me start with remdesivir as I'm pulling up our ventilator. So it kind of depends on what kind of ventilator you're talking about, what we have. But as far as remdesivir, unfortunately, what happens with remdesivir is it is immediately sequestered by the government. The government then, and Judy, please chime in if I'm saying this wrong, the government then allots it to states based on the number of COVID cases. The state of California and Nevada then distribute the allotments of remdesivir per county based on the number of COVID cases. So with that being said, we are not getting an allotment of remdesivir. However, if we need remdesivir, we beg, plead, cry, do whatever we can. And I believe we've been able to get everybody who we have felt has needed remdesivir. We did have one patient that we would have liked to, but the person did very well and ended up being discharged without needing it. But otherwise, we've been able to do a really great job on obtaining it as we need it.
If I could just jump in, Shawni.
As far as the ventilators,
Dr. Coll, so I just got off, I know you didn't, I haven't been able to update you. So I just got off the phone with Renown. So just again, speaking to being able to keep the patients local, they're looking at, where we would keep them local and then we could get the remdesivir from them. And also Nevada County has said if we have located a couple locations, they will then help us get that medication also. So thank you.
Great.
And then Dr. Coll and Judy, another question before we go into the ventilators is, if an elderly patient with comorbidities, which makes them high risk for severe COVID, are presented to Tahoe Forest ED with early but obvious symptoms, how would they be managed? So that's one. And then the other is, what percentage of COVID-19 patients that require hospitalizations are kept at Tahoe Forest, Truckee, versus sending them to Renown or elsewhere? And why? Why would they be sent somewhere else? So a two-parter.
Sure. So I'm going to answer the first one. So typically, if somebody's elderly with multiple comorbidities, they would get admitted to our hospital. They would likely get admitted to the ICU just for very close watch to make sure that we have the resources there if they need them. So I think that's the first question. The second question is, really, when we choose to transport a patient down to Renown, it would have to do with, do they need a service that we do not have here? So for instance, if somebody may have underlying kidney disease and they might need hemodialysis, we do not offer hemodialysis here, and so they would be transferred down to Renown. Most of our COVID positive patients, we can take care of them here, especially with, our previous allotment of remdesivir, our convalescent plasma. We're giving the best care that you can get. However, if there's other things, like we're concerned that they might need a cardiac catheterization, which is because they maybe are having a heart attack, that's when we send people out. So the major services that we do not provide here is neurosurgery, which is not typically COVID related, but if for some reason somebody had COVID and they fell and had a brain bleed, they would go down to Renown. If they are also having a heart attack, they would go down because we don't have the cardiac catheterization or open heart surgery here, or if they look like they might need hemodialysis, which is for acute renal failure. So those are really the three things that I can think of why you would be transported down to Renown versus staying here at Tahoe Forest. Okay?
Great, thank you, Dr. Coll.
Go ahead. Okay, so I can't quite find the data that I was looking for on the ventilators. I believe we have 6 regular ventilators up in the ICU, and I believe there's one more down in the emergency department in case we needed to put somebody on a ventilator right away. We also have trauma ventilators, which are more just high flow oxygen. What we are finding with COVID, just so you know, is people do better off of ventilators. So what we try to do is not ever put anybody on a ventilator. We would rather do what's called proning, which means laying the person on their stomach instead of on their back in the hospital bed. For some reason, that aerates the lungs better, and it is something that we will definitely encourage people to flip over and try to lay on their belly as much as they can when they're really ill with COVID. So we're trying to manage them off of the ventilators. So I'm going to go on to testing, and we can get back to some questions, but I totally appreciate the questions. I love the engagement. So our current state of testing is we have Abbott ID Now. Abbott ID Now is a point of care test. It takes 1 to 2 hours to get back. It is the most useful test when someone has symptoms. It is not a great test for somebody who doesn't have symptoms. So any of our symptomatic patients can get an Abbott ID Now test. However, if that test comes back negative, we then do what's called a reflexive test, where we send that test off for confirmatory testing. If it's positive, then that test is amazing, 99.9% accurate. If it's negative, we like to follow it up with a confirmatory test. Renown has been a great partner, as Judy said, with this remdesivir we had been trying earlier. Last week, I guess we had spoken about asking them for allotments, and they had way more than we do, but they've also been great with testing. They're allowing us to send down 10 tests per 24-hour period, and with that, they give us a 24 to 36-hour turnaround time on that test, which is much faster than anywhere that we can get it. So if somebody is really ill and we have high suspicion and they're being admitted to our hospital and the Abbott ID Now test is negative, we will send it down for that quicker 24 to 36-hour turnaround. We also have the ability to send the test to Quest and also to the state of Nevada. These are all what are called PCR testing. So we're looking for the virus within, typically we're putting it into the nasal pharyngeal area, which is basically way up the nose. We can also do it from a bronchoscopy specimen, which is getting sputum from down low in the lungs. The Quest and state of Nevada turnaround time can be anywhere from 5 to 9 days, unfortunately, which is why Renown's 24 to 36-hour turnaround time is really amazing. We used to have the ability to send it to the state of California, and we do not have the ability to do that anymore because they've been so overwhelmed with their major outbreaks in the prison system, et cetera. So the state of California has just been too overwhelmed, but the state of Nevada has been absolutely amazing to both our California and our Nevada hospital. We also have antibody testing. We have been offering that through Quest, but we're also now doing it within our hospital system here. I just want to reiterate, antibodies typically protect people from those conditions in the future, but with COVID, we do not know if it's protective at all. We can basically say that it's likely that you've been exposed to it as long as there wasn't a cross-reactivity with another coronavirus. So it's kind of one of those sticky subjects as far as, utilization. They really feel like there's not much clinical utilization at this point. It's more epidemiologic or kind of studying the population of who maybe has been exposed and who hasn't. We've also been very, very fortunate through the foundation and Carly to have a donor be able to buy us what's called a BioFire. They're buying one for both Incline Village, yes, and for Tahoe Forest. This BioFire does actually multiple things. So number one, it is going to be able to test for COVID, but it also tests for, I think it's 23 other viral illnesses. So one swab, I send it off, it tells me whether or not you have influenza, if you have RSV, if you have COVID. There's multiple different things, and it's going to be extremely helpful when we get this in. Now, it has been purchased, and I've heard that parts of it are here, but the whole entire setup is not quite here yet. So what we have done, so, it feels like we kind of,
Okay,
Charlie's waving at me.
Yeah, I'm waving at you if you don't mind. And I think that Harry talked a little bit about this, but if you could talk to the coordination with the testing facility, which is at the Placer County across the street here in Truckee, and if you have the percentage of test positivity that we have seen, that would be helpful, as well as I have some specific questions around the BioFire. Let me just see, hold on, I lost it. Oh, the accuracy. How accuracy is the upcoming BioFire? Do you know the cost of each test? And are those test kits readily available because of some of those challenges with those Abbott reagents? Is this going to be a challenge for Tahoe Forest and Incline?
So I do think it's going to be a challenge. But with that being said, we are hopeful that we will get the reagents that we need. The BioFire, my understanding is the accuracy of the test is slightly better. All of these PCRs are only about 80 to 85% detected, which is why when we have very clinical high suspicion, we continue testing people, because and we do not lift our PPE or that personal protective equipment standard. We don't lift that if we're really suspicious, even with continue to have negative tests, because we want to make sure that the staff and physicians are safe. What was it seemed like there was one other question in there.
The cost of the test, if you happen to know.
Yeah, so I do believe that it's more expensive. Judy, if you know, I was thinking it was between $450 and $600 for that 23. It's a more expensive test, but it's more thorough, and I think something that our community will really want to be able to have done. So, a lot of questions that I get is, wait a second, I'm kind of confused. Oh, and then the percentage of tests. I'm going to actually ask Harry to talk to the percentage of tests. He mentioned, that we've had 167 positive out of, I think, 3,200. So somebody get their calculator out for me and calculate the percentage of positive there. I think it's 5% or something. But, and then as far as the coordination with the county, we really don't have much coordination with them. They're kind of their own entity. Judy, I don't know if you have any thoughts on that coordination.
Yeah, so with Placer County testing site that's across the street from Tahoe Forest Hospital. So in the state of California, made a decision to have 80 test sites throughout California. This is one of those test sites, so it is completely run by the county. And so it's been a very busy, I think all test sites are busy, but at one point we were actually the 6th busiest that was in Truckee in California. And then the Washoe County Health District, also for those who don't know, offers asymptomatic testing through getting on their website and making an appointment. So for Placer County, it's their own business. We do share information because we do hear from community members if there's a delay getting their tests or some communication. So we have let them know those frustrations.
The positive lab test percentage, based on the calculations I did last week, across California and the U.S., it's almost the same at about 8% of all lab tests, I think, were positive. But in our local areas of Placer and Nevada County and local areas, I was coming up with about 2.5% to 5% positive lab test rate in our region last week.
Yeah.
I appreciate that, Harry. Thank you for, he's our numbers guy. He loves the numbers. So I think one of the main questions that I get right now is, we had less COVID cases before and we closed the whole hospital down, and now we have way more cases. Why are we completely open? And I just kind of wanted to talk a little bit about that dichotomy and why it's that way. And I think the first thing is that, number one, we've learned a lot more about COVID and how to prevent it. And we have put in processes in place to make people safe. So obviously that is, keeping our patients, our staff, our physicians, everyone safe is one of the most important things for us, and has been a guiding light through this whole pandemic, is really putting safety first. So I think that's really important. Harry mentioned it also. It's super important not to ignore other diseases. Like, we have other things going on besides the pandemic. And so we needed to figure out, and that's what took time when I was pulled out of that clinical duty for a couple of months, was really putting those processes in place to make sure everybody's safe so that we can continue to take care of all of these different things. And then the other thing I just want to mention is that behavioral health is a really big piece moving forward. I think a lot of people are having anxiety and depression due to the pandemic, due to the fact that they can't get out and do their normal activities, especially in our beautiful summer. It's so hard. So, you guys may know that the foundation really helped with that over at Incline Village, and we have really been expanding our behavioral health overall, and we have 2 new nurse practitioners in psychiatric care, along with a whole slew of behavioral health that I'm so proud to work with. I think that the other thing, just so you know, is we built throughout this whole process, the whole executive team built lots of partnerships and relationships. Judy talked about the one with Renown. I was often on calls with the chief medical officer down at Barton. They helped us to facilitate a lot of different things. I was sending our tiered closure approach down to them so that they could replicate it down there. We've really been utilizing the resources around us to get the best care. I spoke with contacts at Stanford and at Davis all about testing. So it's just something that's been really great team building. And then what's to come? We're really focused now on kind of winter conditions and how can we continue. As you know, our winters are a little bit more severe than in the Bay Area. And so how can you really evaluate patients in the best manner? What we're finding is adults are easy to evaluate in the car, but kids are not. It's very difficult to do a really good pediatric exam in the car seat or on the parent's lap. And so we're really looking to obtain space for them and to figure out how can we put processes in place to make sure that that office is clean and up to the standards that we have for the rest of the area. And then, of course, we always continue to explore more options for testing, for more rapid testing, for reagents that are more available. And the new one that has just come out, which we are not exploring, but would be kind of fun, is they actually are now training dogs to sniff out COVID. I don't know if you guys have seen the literature about this. They plan to place them in airports and train stations and stuff, and basically you're going to have to walk by a dog, and if they smell COVID on you, out you go. No plane flight for you. So I think that's amazing. Dogs are already sniffing out cancers. UC Davis has a huge cancer program with their dogs, and they, I'm sure, will be getting on the bandwagon for COVID. And I am so sorry, Carly. I went way past my 20 minutes, but I hope that you guys found this to be interesting, and I'm happy to take any other questions.
I do have one question for you, Dr. Coll. And it's sort of related to your behavioral health point, but is there an opportunity for COVID survivors to get together to share their experiences and ongoing issues? Has there been any community groups formed to do that?
You know, I have not heard that, but I think that that's a great suggestion, and I'm happy to take that back to the behavioral health team, because I think you're right that that is a great resource within our cancer center to have that kind of collaborative group of people. And you're right that the symptoms of COVID can be long-standing and lingering, and also I think the fear of what that brings up can also be there. So yeah, I think that's a great thing, and I'll definitely bring it up to our behavioral health team. So thank you for whoever suggested it.
Absolutely. And then one other thing, you answered this question partly, but there was a follow-up around the treatment for plasma, remdesivir. Would that happen early on in the course of infection, or would a patient have to become really sick in order to get that?
Yeah, that's a great question. So the clinical team, so first of all, since I'm an OBGYN, I do not take care of our intensive care COVID patients. And so, you know, I could be misspeaking right now, but it's my understanding that if people with comorbidities are in our ICU, then yes, that we're looking at getting remdesivir. You know, potentially a young, healthy patient that's not in the intensive care unit that might be on med-surg or who is not in the hospital, we would not be looking at giving them remdesivir.
And that was the question about high-risk patients. So thank you so much. That was perfect. And we had someone who just mentioned, thank you very much, Dr. Coll, thorough and clear presentation. So just some
good. Thank you. I really enjoyed it, and I'm happy to speak to you guys anytime. I'm always available, and my email is S and then my last name, which is kind of an unusual spelling. It's COLL at tfhd.com. So that's my last name. And then, Carly, I think you were going to play a video.
Yeah, I am going to play the video. I have it all queued up here. So one moment. It's only 1 minute long, so I'm just going to pause it for a second. Pause. Okay. And I just want you guys to know that this is made by me, purely amateur, purely for fun, but I think it really speaks to the spirit of the medical staff and the nurses and everyone who has been kind of involved in this pandemic. Yeah, and I just want to say, for those of you who are on, as Dr. Coll mentioned, certainly PPE was a challenge, and through donations, we were able to fund a vast majority of the PPE expenses, both in Incline and at Tahoe Forest, and we're just incredibly grateful for all the community support. And you can see some of our frontline folks in action here. So I'm just going to play this for you. And then after this ends, we'll be done, and I'll record it, and I'm happy to send this out, and you can share it with loved ones too.
Can you turn up the sound?
Oh, yeah. Hold on.
Yeah.
I know why. Because of...
There's the box to intubate people.
Yay. Yay.
It's kind of cute. So that's just a lot of the staff. Obviously, you saw them taking care of patients in the snow, in that full gear, and just, what everyday life is for us now. It's very different than it's been in the past.
Okay, and that's it. And I do have one other note, and I think you know who it's from, but it says, "Thank you, Dr. Coll. I feel so fortunate to have had you deliver Hokea."
Yay! I'm so lucky to have been there.
So thank you all so much.
All right, you guys, thank you so much.